We're ready. Okay, good evening, everyone. Um, Today is September 25th, 2019, and it is 5:31 p.m. As a quorum of the board is in attendance, I would like to call to order the meeting of the Central Health Board of Managers. The first item of business is citizens communication.
Good afternoon. My name is Anais Drews, Program Manager here at Central Health. For the purpose of citizens communication and public hearings held during the course of a Board of Managers meeting, the board will follow the guidelines set out below. Number 1, any person may speak during citizens communication portion of any Central Health Board of Managers meeting at which citizens communication appears on the agenda and during any public hearing that is posted as such. Number 2, in advance of speaking, an individual must complete a sign-in sheet that includes the person's name, address, and organization being represented, if applicable. At the individual's option, he or she may provide a telephone number and email address. Number 3, the chairperson or presiding officer will call speakers in order in which they are listed on the sign-in sheet. Number 4, each speaker has a limit of 3 minutes. Each speaker may address the board only one time during any particular citizens communication or the particular public hearing. Number 6, a speaker may not donate his or her 3 minutes or any part thereof to any other speaker. Number 7, the speaker does not have the right to speak if he or she signs in after citizens communication or the public hearing is closed. The hearing will be closed once the last individual who has signed in has spoken. Number 8, depending on the number of persons wishing to speak, the chairperson may, in his or her discretion, impose additional procedural guidelines in time and or manner of the speaker's presentations to ensure the efficient and effective conduct of the meeting. Due to the restrictive nature of the Open Meetings Act and to fulfill proper notice of meeting requirements, the board is restricted from discussing any item that is not posted on the agenda for that meeting. Therefore, the board may be unable to address your comments, and thus citizens communication is most usually a one-way communication vehicle. However, a Central Health staff member may follow up with you regarding the topic of your communication as appropriate. With that, I will introduce Mia Greer, Community Coalition for Health.
Good evening, board members. Thank you for allowing me to have this time to speak with you. I'm also here representing not only Community Coalition for Health, but I am going to be a new member of the community that I represent, which is Austin Colony, Dale Valley, Horns Bend, Eastern Crescent, and also the church community. I've brought some of our church members here because we have 2 issues that I would like to address to the board. The first issue is there was an RFP that was sent out that addresses the community that I represent. And one of the things I did was ask for open records, and I was told that I could not get those open records. And I received a letter stating one of the reasons that this particular organization received the proposal of the budget that they asked for was because they had a professional and a end to the Latino community. They were specializing in the Latino community. And so when I read that, it made me think, so what are we going to do with the African American community if we have Latino company that is going to specialize in Latino community? Who is specializing in the African American community? Because right now it doesn't seem that anyone is focused on what is happening to my community. So that's one of the things that I would like to address, or I'd like the board to think about when you are offering funds to people who are focused on their own community, because I'm focused on my community, and the African Americans want to see something done in their community with as much fervor and as much budget as any other community does with you guys, with Central Health. The second thing that I would like to bring up is a lot of your meetings are done on Wednesdays or during the day or all the way down here. And our culture on Wednesday nights, we have church. We have church. For me to bring these people down here tonight, we had to get permission. we had to ask our pastor, is it okay for me to take these people out of service so they can support me down here at this meeting? Every meeting that if you look at your own agenda, the meeting that says open to the public are on Wednesdays. African Americans, and probably Latinos, I believe, but I know African Americans are at church on Wednesday nights. And so we don't have a voice here because we are listening to God on Wednesdays. We're not listening to Central Health on Wednesdays. So I have brought this to the attention of quite a few people who work here that, first of all, it's hard to get here. There's not a lot of parking. It is not easy to come here at 5:30 on any day, let alone on a Wednesday night when we should be getting prepared for our service that we have every Wednesday, when you are wanting our opinion on Wednesday night. And that's it.
Thank you for being here. We appreciate it.
That concludes citizens'
Understood.
communication.
Thank you.
For this evening.
Thank you. I would like to note for the record that agenda items 5, 8, and 9 will not be discussed this evening. Those items are 5, receive and discuss an update on an agreement with Social Finance, Inc. and its subsidiary Path LLC for permanent supportive housing and wraparound services to be provided to homeless Travis County residents. 8, discuss and take appropriate action on healthcare service delivery expansion in eastern Travis County, including project timelines. And 9, discuss Central Health owned or occupied real property and potential property for acquisition or lease, including the downtown campus and properties located in eastern Travis County. We will now move to the consent agenda.
I move that the board approve consent items C1 through C4.
Okay, we have a motion. Is there a second? We have a motion from Manager Valadez and a second from Manager Musaitov. All in favor? Aye. Opposed? Same sign. Any abstaining? The consent agenda passes. Regular agenda. Number 1, discuss and take appropriate action regarding Central Health's proposed 2020 tax rate. A, total maintenance and operations tax rate. B, total debt service tax rate. And C, total ad valorem tax rate. Lisa Owens and Jeff Canota will be presenting. Thank you for being here, as always.
Thank you.
All right, well, thank you, everyone. It's good to be back. After the approval of our budget, the last step in this process is the approval of our tax rate. The tax rate has not changed since our last presentations. After today's meeting, the tax rate will go to the Commissioners Court next Tuesday. So just to recap, as we've presented in our public hearings and to this board, the proposed Central Health property tax rate, maintenance and operations rate is 10.4906 cents per $100 evaluation. Debt service rate is 0.667 cents per $100 evaluation. And the total rate is 10.5573 cents per $100 evaluation. We did compare the average taxable homestead value year over year, taking into consideration the changes in the assessed values and the changes in the proposed tax rate. We estimate an annual impact to the average homestead taxpayer of approximately $23.07. A reminder of our homestead exemptions, which have not changed this year: 20%, the maximum allowable by law, and $85.5 thousand for over 65 and disabled. I'm happy to answer any questions.
Yes, Manager Bell.
I'd like to make a motion.
Before you do,
Yes. Yes.
I know we're following good parliamentary procedure by making a motion first.
Yes.
But how this works under the tax code is we have to make 3 separate motions and take 3 separate votes by roll call. So you can make the first motion, get a second, and then we can discuss and take the roll call vote.
Thank you. Appreciate it. I'd like to make the first motion for the maintenance and operations tax rate. I move that the property tax rate be increased by the adoption of tax rate of 0.104906 for maintenance and operations, which is effectively a 0.4% increase in the tax rate. And there is hereby levied for the current tax year an ad valorem tax rate of 0.104906 for each $100 valuation of all taxable property for general operating purposes.
Okay, seconded by Manager Musaita. Any discussion? Hearing none, we'll have a roll call vote, correct?
Correct. I'd like to recognize Ms. Yamas.
Vice Chair Sherry Greenberg,
Aye.
Manager Shannon Jones,
Aye.
Manager Maram Musaitif,
Aye.
Manager Julie Oliver,
Aye.
Manager Cynthia Valadez,
Aye.
Manager Julie Zuniga,
Aye.
Dr. Charles Bell.
Treasurer Charles Bell.
Aye.
Okay. The motion passes. We have another one.
For the debt service tax rate, I move that the property tax be increased by the adoption of tax rate of 0.000667, which is effectively a negative 8.1% or a negative 8.1% increase in the tax rate.
We have a second.
A second.
Manager Bell seconds. We will have another roll call vote.
Treasurer Charles Bell,
Aye.
Vice Chair Sherry Greenberg,
Aye.
Manager Shannon Jones,
Aye.
Manager Maram Musaitif,
Aye.
Manager Julie Oliver,
Aye.
Manager Cynthia Valadez,
Aye.
Manager Julie Zuniga.
Aye.
The motion passes. We now have another motion. Another roll call vote. It will be the same. We will,
For the total tax rate, which includes maintenance and operations and debt service tax rates, I move that the property tax rate be increased by the adoption of a tax rate of 0.105573, which is effectively a 0.3% or 0.3% increase in the tax rate.
we have a
A second.
Manager Bell seconds. Again, we will have a roll call vote. Yes,
Just a question.
yes.
Do we have any numbers in terms of where, with the adoption of this, where we would rate with the top major hospital district or healthcare districts here in Texas?
We don't have all of the tax rates yet, but when we look back at last year's, I think we were, let's just call it around 10.5 cents. Harris County was at 17 cents. And then most of the other major districts were higher, up to about 27 cents. And then when you look at the overall tax burden of the hospital district, kind of the overlapping burden, we're typically about 4.3% of the overall overlapping taxing jurisdiction burden. And that ranges from a low of where we're at, 4.3%, up to about 10%. I think Bear and maybe Dallas are around 10% of the overall burden.
So of the 5 major metropolitan areas that have healthcare district or hospital districts, will still remain the lowest?
That's correct.
Yes.
But they all run hospitals.
Yes.
Yeah.
Yeah, the big difference
That's
is
the
they
big
do.
difference between us.
Yes.
Thanks.
And they all have substantially higher debt. Is that correct also?
They have debt, they have, so a lot of them have retirement system debt.
Right.
Which you've spoken about.
Yes,
And then
yes.
some of them even might have post-employment benefits debt.
Right.
So
So,
they have substantial debt, and that's a big difference than what we have on our side, which is very little debt. Most of the districts have, again, they're much bigger, but hundreds of millions of dollars of debt is not uncommon in the larger districts.
right, so they have debt as far as debt for building hospitals, but they also, a lot of them have defined benefit plans where they have to show
On the
that,
pension plans, that's right.
pension plans on their,
And they've
on
been
their
around this
balance
long.
sheets.
They've been in existence way much longer.
Yes, absolutely. Okay. Any further questions or discussion? Again, we will have a roll call vote. Each board member's name will be called. You can answer yay, nay, or abstain.
Treasurer Charles Bell.
Aye.
Vice Chair Sherry Greenberg.
Aye.
Manager Shannon Jones.
Aye.
Manager Maram Musaitif.
Aye.
Manager Julie Oliver.
Aye.
Manager Cynthia Valadez.
Aye.
Manager Julie Zuniga.
Aye.
Thank you, members. The motion passes. Item number 2, thank you very much, again, for all of our staff who have put in hours and hours and hours into our budget process, and I believe that we have now completed that with the adoption of the tax rate.
And the board too.
And the board, but I want a little round for our staff. Thank you very much. This, I know, was a prolonged process this year because of a situation with appeals and getting the certified roll later, so we really appreciate all that you have done. Thank you very much. We'll move now to item 2 on our agenda, receive and discuss a presentation on Community Care's fiscal year 2020 budget. There's no action necessary on this item. Dr. Jason Fournier will be presenting.
Thank you. Thank you, Manager Greenberg. And good evening, Board of Managers. Our distinct pleasure from Community Care's perspective to be here to present our upcoming budget that begins October 1st, aligns from a timing perspective with Central Health's budget process as well, and as your co-applicant relative to the federally qualified health center. Joining me this evening is Community Care's fairly new Chief Financial Officer. You may have been aware of the fact that Carolyn Konecki had retired earlier this year, and we went through a very competitive process to secure our next Chief Financial Officer. We're very pleased to have Joy Sloan having joined us back at the end of May. Comes to us with both rural hospital experience, but as important, if not more important from my perspective, is having community health center experience as well. So pleased to have her joining us this evening.
Thank you.
So I'm going to kick it off. Really, the first slide is really just going ahead and walking through some of the things we want to talk this evening to you about, which is really just kind of setting up what our budget looks like for the forthcoming year. I think it's, we're going to talk about, on the community health center side, we talk a lot about what are known as encounters, which is when we have a clinician like a physician, nurse practitioner, physician assistant, dentist. Those are face-to-face interactions with a billable clinician from the federal government's perspective. So it's a little bit atypical, has a lot to do with the way that we get paid under the Medicare and Medicaid program and recognition at the federal level. We want to talk a little bit about some of the budget pressures as well and assumptions that were made, because there's some fairly significant budgetary pressures. We think they're going to be mitigated over time, but we do want to go ahead and make sure that you're aware of some of the things that we're considering as we've gone through this process. And then Joy's going to walk you through what our budget actually is looking like relative to the upcoming fiscal year. And then towards the end, I'll actually chime back in and just provide some overview and oversight as it relates to trends that are, I think, of importance for you guys to recognize here as the Board of Managers and as our partners. As always, first and foremost, we cannot do what we do each and every day through our clinical system without your partnership and without your support. We are part of Central Health's enterprise as a co-applicant and as a 501c3 with our Community Health Center Board. What we do possible through their volunteerism as board members and with your support as Board of Managers and through the strong support of taxpayers here in Travis County, we're able to provide direct care to literally tens of thousands of individuals. This slide, many of you have seen before. We always think this is really about the individuals, families, communities that we serve here within Travis County and within Austin. It's always important for us to reflect on what does that patient population look like. So this is data from the 2018, calendar year 2018 that you're looking at right now. And it's part of a report that we have to submit every February up to the federal government. It's called the Uniform Data System Report. So in 2018 calendar year, we served 98,549 unique individuals. Just some real high-level highlights. When we take a look at our demographics, we have a very diverse patient population, but about 56% of our patients are Hispanic Latino. So think almost 56,000 individuals. When we look at our African American population, it's about 11 to 12,000 unique individuals. And when we look at our white-only, non-Latino population, it's about 16,000. Our Asian population is sitting at around 7% or so. So think 6,000, 7,000 individuals, so very diverse. 34, this isn't up there, 33 to 34% of our patient population speak a primary language other than English at home. And so a lot of diversity as it relates to languages that are being spoken through. First language spoken is English, then second Spanish, third is Arabic and Vietnamese, and it changes depending which site we're at. So a lot of variability as it relates to that. 94% of our patients are at or below 2 times or 200% of the federal poverty level. So these are
What percent was that?
94%.
94% are at or below 200% of the federal poverty level.
Correct. And Manager Greenberg, that would actually be higher because not everyone reports their income to us because we have a lot of folks who are either CHIP or Medicaid. And so those folks typically don't volunteer. That's a voluntary reporting. So we think it would be higher if we had actual reporting from folks. And you can see, as it relates to income, we only had a little bit over 59,000 unique individuals report their poverty level to us. Again, with almost 30,000 CHIP Medicaid, the vast majority of them aren't reporting their income to us. A little different than most community health centers, we actually skew from a gender perspective. We actually we serve more males than most community health centers, but you can still see we're almost at 57% female in terms of patient population served. Most community health centers are going to be closer to about 66%. So we're serving more males. And that's just simply because the model for health centers across the country really skews towards prenatal care. And we do our fair share on that. We are delivering with our partners through DelMed, as well as through Ascension Seton and Seton, Maine. Almost 3,000 babies this year will be delivered. And we provided prenatal care to almost 5,000 unique individuals last year. You can see payer mix. So payer mix, we're talking about what the makeup of insurance is. Overall, about 57%, a little bit over 57% of our patients in calendar year 2018 were uninsured. When you take a look and we break it out and we look at an adult population, including an older population, it actually increases to 66%. And then our pediatric population is uninsured with 23.8% of the roughly 22,500 kiddos that we serve being uninsured as well. So we have uninsurance in our kids and we have a high level of uninsurance within our adult population as well. And so you can see that broken out down at the bottom right there. So what's important to note is this is from last year, calendar year 2018. And so when we take a look at this calendar year, we have projections. We are projecting that we're going to serve for the very first time over 100,000 unique individuals through our health centers this year, and we're going to surpass 101,000 individuals by the end of this calendar year. So there's been some significant increase in services overall, and you'll see that as it relates to how not only our direct encounters, those face-to-face clinician visits, but some of the alternative visits as we're looking at alignment with Central Health strategic priority of access to care, which is also a strategic priority of community care. Really looking at how do we increase not only the direct services, but some of the ancillary services we provide. We'd be remiss if we didn't recognize the great work of our clinical care teams. You know, I have the privilege, as does Joy, as does Yvonne Camarena, who's our COO in the audience, of supporting a great team. We have almost 900 strong Central Health employees. I think you know that we basically contract back for our employees through you guys as your partner. And when we take a look at that, we do what we do every day because of the commitment of our staff. And they're committed to high quality of care. And for the third straight year, we've been recognized by the Health Resources and Service Administration, who provides our community health center funding, which this year is projected to be about $6.5 million in direct funding on the community health center program side. They recognized us as a health center quality leader in the nation. So that puts us in the top 25 percentile and higher as it relates to, we don't know if we came in at 25 or at 10. They're still, they're keeping us hanging out on that. One of the things that we're really proud of, though, over the last 12 months, it's really the first bullet. We shared this with our board last month because we received the award in August, was we were only one of 2 out of 73 health centers in Texas to be recognized from a dollar valuation. So the HRSA is going ahead, the federal government's providing us a quality award, so there's monies tied to this. It's not huge, but it buys us some community health workers, so we want to make sure that we're maximizing access to all of our resources. but we were one of 2 health centers in Texas recognized as a clinical quality improver, which means on comparative to peers across the state and across the country, we really enhanced our quality of improvement significantly over the last 12 months. By way of example, here's our preventive health screenings as reported up to the federal government earlier this year. And the items where you see up at the top, you can see lines on this graph itself, and the bars tell you the actual percentages based on the particular preventative service. So I'll go ahead and I'll take a look at dental sealants on the far right just to orientate you. So in green, we performed at a little bit over 60% of our children ages 6 to 9 had a dental sealant. And comparative to national averages, which are above in the light pink box and the blue box, our state and national averages, we surpassed the state and national averages. When you see the little green check box next to it, or check mark, that means we were above both the state and national average for community health centers. When you see the X, so like screening for clinical depression and follow-up plan, where you see 2 X's, we were below what the state and national average was. So you real quick snapshot, you can see on preventive services, we're doing very well for most of these measures comparative to peer community health centers from both across the state of Texas and across the country. I would ask you to really look, we don't mind comparing ourselves to across the country, but there's various differences across the country to comparative to Texas. So the true comparison is really health centers here in Texas, just simply because a lot of the other states have expanded Medicaid and folks have access to additional resources as well. Childhood immunization, that's one we're very proud of. Still a lot of opportunity when you take a look at this, right? We're at 53% above the state average and we've progressed year over year. So there's some pretty good trends here as we look as a whole. It's similarly on our chronic disease outcome management, right? This is impacting our patients' health and well-being, aligns with our mission, aligns with our access to care initiatives, health equity. We want to be looking at the various different interventions that we have at community care with your support from Central Health and seeing how we're doing. So the one measure on here is when you look at it, when it goes lower, it's actually better, is the one on the far right, which is a diabetes measure known as hemoglobin A1C. So we just put a little reminder up there that lower is better on that one, but the rest we actually want to see increasing overall. And so we've seen some positive trends there overall. The HIV linkage to care, we're doing very well there, but that number is fairly small, so all it takes is just not linking a couple people within the time frame that's needed for that to drop, and that's why we saw that drop. The next slide, and I'm going through these pretty quickly because this is more for your reference after, because we're going to get into the heart of the budget, but we would just want to point this out. One of the things that we do consistently is really take a look at the data that's available to us. And we really want to understand how are things changing within our patient population. What this particular slide demonstrates is that over time, when we take a look at the work that we're doing in conjunction and in partnership with our patients, we're actually seeing the burden of chronic disease increasing. We're seeing more folks with hypertension. We're seeing more folks with asthma. We're seeing more folks with diabetes. And what's interesting here is if you keep in mind, as you look at this in future, the next slide where we'll talk about what the percentage increase in encounters has and unduplicated patients is, what you'll see if you compare the percentages in green here to the percentage from last year in terms of growth, the chronic disease is growing faster than our patient population is. So that means our patient population is presenting with more chronic disease, and yes, Manager Greenberg, they're sicker. Okay, the one exception here, and this is kudos to our chief medical officer who isn't with us this evening, happens to be his wife's birthday, so we give him a pass, right? Dr. Alan Shelsha, but really the core clinical team, so many folks involved with this, our partners at CCC supporting our work relative to hepatitis C. If you notice on this, we actually see a negative number. And that's because with hepatitis C, as you very well know, we can actually cure folks with hepatitis C. And over the last 3 years, we've cured almost 600 individuals, not with the CCC's partnership, yours, but also with pharmaceutical companies who have come in and provided high-cost Hep C drugs through a patient pharmaceutical program to support our patients and access to things like Truvada and other Hep C medications. If you know much about the drug, a course over depending on which drug it is, it's usually a 6-week plus course, and it could be upwards of anywhere from $38,000 to $60,000, depending on what the drug is, right? So we can only do this with partnership, but that's something through our GI specialist, gastroenterology, intestinal specialists, that we've been able to accomplish quite a bit on this. So the next is really just some of the growth, right? So what's critically important, we know here in Travis County, we have a lot of folks who are uninsured, right? The most recent American Community Survey data points to about 172,000 uninsured individuals. For folks less than 200% of federal poverty, it's roughly about 356,000 individuals out of an overall population of about 1.2 million, right? And these are, I'm just ballparking the numbers, but they're pretty accurate in terms of the uninsured at 172,000, and 356,000 to change over 200%. What we've been able to do with your support, both financially, but your moral support and our guidance relative to expanding services, is really to adhere to that. So you can see over the last 5 years, and this includes, and Joy's going to spend quite a bit of time just walking through the budget, but you can see the last 3 years of actual activity, what we're projecting through the end of September, which isn't that far away right now, 4 more days, 5 more days, right? So we get to the end of September, and then what we're projecting for 2020. Our upcoming fiscal year, 1920. So you can see there's a trajectory up there as it relates to the overall encounters. And when you compare back to 2016, our fiscal year 2016, we've grown on a per encounter basis by 18% over the last 5 years is what we're projecting by the end of next fiscal year. So that's a lot of growth overall in terms of the services, and we do that because of your commitment. So the next is really, not only do we do this with this face-to-face encounter where it's mediated by a clinician, so again, a physician, nurse practitioner, physician assistant, dental assistant, behavioral health therapist, could be a specialist. We have cardiology, pulmonology, other specialties that are inside and housed at Southeast Health and Wellness and North Central. It also includes psychiatry. So there's a lot of those face-to-face are the clinicians, right? But then we also have a lot of alternative visits. One of the things we've worked with our partners at Central Health and Community Care Collaborative, CCC, over the last several years is the ability to provide atypical visits. And you don't see this much within healthcare, where we're getting recognition for community health workers. We're getting recognition for care coordination, care management folks. We're getting recognition for our nurse interventions and visits. So a lot of staff. So we've deliberately, under Yvonne's leadership and others, we've grown that. So you go back 3 years ago where this really started, we saw 70,000 alternative visits for MAP and sliding fee scale patients, so our uninsured patients here within Travis County for the most part, right? We do serve folks from across Central Texas, but the vast majority of folks are coming from Travis County. And so when we take a look at that, several years ago, we provided 70,000 alternative visits. This year, we're projecting for our MAP sliding fee scale almost 140,000. Comparative to 3 years ago, that's a growth of 96%. So while we're growing access on the direct face-to-face, these handoffs to other staff members who are part of our care team, we've had the opportunity to present and talk to each of you before as a collective group about our transition and care model. Part of that is emphasizing and allowing our care teams to do more. Be it our nutritionists, be it our clinical pharmacists, be it our nurses, our care coordinators, community health workers. And that's what you're seeing here. So these are touches that weren't occurring several years ago to the extent that they are now. And that occurs because of your commitment, our commitment to trying to evolve our care model to make sure that we're increasing and fostering improved access to care as a whole. So before Joy jumps in, I got the next 2 slides just talking about some fiscal pressures, right? One of the ones that's important to all community health centers right now across the country is that our federal funding is at risk. And not the whole federal funding, but 70% of it. So on the left-hand side on this slide, you can see there's really 2 pools of money for which the federal appropriations occurs. One is ongoing annual appropriations that occurs, which is discretionary as part of the budget process through Congress. So that makes up roughly 30% of our funding. The other part is 70%, which is funded through a community health center or a health center trust fund. That was established as part of the Affordable Care Act back in 2010. A couple of years ago, it was reauthorized as part of the Children's Health Insurance Reauthorization Act. So you may recall 2 years ago, CHIPRA passing. So our reestablishment or renewal of that trust fund occurred 2 years ago. It expires at the end of September. Without congressional action, 70% of community health center funds goes away. And so what does that mean for community care? What does that mean for Central Health? What does it mean for our community as a whole? That translates, we right now, based on last year, we had $6.9 million in federal funds. I said 6.5, that's what we're projecting this year. The 6.9 included our quality award. We can't bank on that till we receive it next year, so we don't put that in the budget, right? But when we take a look at it, if we used at the 6.9 million last year, it translates into roughly $4.5 million removed from our budget should Congress not act. There's been a lot of advocacy across the country. The unfortunate thing is it's not going to get done by the end of September. And part of that is because there's a lot of interesting things that have happened. One of the most interesting things that have happened is there isn't much healthcare legislation moving forward right now within Congress. Ours was one of the only bills that was moving forward. It actually came out of the Senate Health Committee, and it also came out of the House Energy and Commerce Committee with 5 years of funding in the Senate and 4 years in the House. Unfortunately, though, there's a ban or maneuvering that's occurred relative to surprise medical billing, and so it's slowed down this process for us. So for the foreseeable future, we're expecting that our trust fund is going to be authorized on continuing resolutions, which means it might be 30, 60 days at a time. The Health Resources and Service Administration has indicated that they've got enough funding to keep the program afloat for 3 months, roughly, should Congress not act. So this is of critical importance to us. When we take a look at it for us, because the proportionality of our funding is only about 5%, 6%, a little less than 6% of our overall funding comes through the federally qualified health center program, it will only impact about 5% or capacity to serve about 5.5% of our patients. For many of our brethren health centers, it has the possibility of impacting 20, 30, 40%. So it's significant. So that's one of the pressures. We continue to have strong bipartisan support. I really do believe this is going to be a timing issue more than anything. But the other part we're trying to push for is at least 5 years of sustained funding approved instead of this 2-year cycle. You know, Wile E. Coyote's going off the cliff. We've been talking about this as a health center cliff for a while. That's why it's there. So sorry, it's a bad joke, but you know, we're not happy about going off that cliff. We've talked about the health center cliff now for the last 8 years, and we've gone off of it. This will be our 3rd time in the last 6 years going off the cliff without Congress acting by the time it expired. The next is one that I think is critically important for you to be aware of and for us to be mindful of, is we're seeing a shifting in our payer mix. We actually saw, and you'll see this further on, so last year in calendar year 2018, we served 57.28% of our overall patient population of 98,549 unique individuals were uninsured. This year it's going to be, for our fiscal year and calendar year, we're projecting it to be a little bit less than 60%. So we're growing our total patient population. At the same time, we're seeing more folks coming through our doors who are uninsured. And we've struggled with this with our own board this year and talking with our finance committee. Joey was hearing this as she joined us in May, and we're like, okay, what's going on? We're seeing Medicaid's less, a little less in CHIP, we're seeing more uninsured folks. And we're like, whoa, what's happening? And you may have seen the data. I know that Ted Burton and your communications office does such a terrific job. What I got alerted to was the notice they sent out about the uninsured rate for Texas again. Unfortunately, we have the distinction of having the highest level of uninsurance in the nation. What also came across there was the fact that it increased, and you can see that it increased fairly significantly from 17.3% to 17.7%. And this is a little bit outdated, right? Because that's based on 2018 data, and we're almost not quite through, but 3/4 of the way through 2019. At the same time, Medicaid enrollment at the state level during 2018 dropped comparative to 2017 by 0.7. And we're actually seeing that within our patient population. And then you couple it to the third issue, which I know you're very much aware of, but is having a real impact with our patients. Many of the families, communities that we're so privileged to serve are drawn from immigrant backgrounds and immigrant communities. And there's a proposed rule that was issued in mid-August by the federal administration that changes the rule relative to public charge that will take effect on October 15th. We have not anecdotal evidence, we have direct evidence from both staff and patients about the impact this is having. We had a mother who chose not to participate in a WIC program because she was concerned, even though her child and herself were both legitimately eligible for participation in that program, chose not to over concerns relative to another loved one who might sink permanent residency into the future. And these are real difficult decisions that are being confronted by our patients. What it's translating into is folks making decisions potentially that go ahead and have them forego participation in federal programs like WIC, Medicaid, and others that they're otherwise eligible for. We're working with our partners at Central Health on both a staff and patient education campaign. Really appreciate the work of Perla and others. We've been working on this for some time, Stephanie McDonald and others, to really go ahead and educate. Our role as a healthcare provider is always to educate. We need folks to know that if you're a kiddo and you're Medicaid, it won't ever count against public charge. If you're a prenatal patient, it won't ever count. WIC won't ever count. But these are things that as a community we need to get the word out there. We're not in a place to provide legal advice, but we can certainly educate in terms of what is. And you may know already that 2 years ago we did a Know Your Rights campaign relative to immigrant rights within our health centers. And so we're very proud of that work. So with that stated, I'm going to hand over the pointer, the controller, over to Joy. So Joy, please.
It's always the other button, right?
It is.
So the actual fiscal year 2019 and 20 budget, we kind of go through an extensive process, which I am understanding this year for the first time. I came in as they had started the budget process and have kind of gotten up to speed as they have done an excellent job of putting it together. We currently have 33 service delivery sites that are approved by HRSA that include 24 clinics. And in the next year's budget, we've included the school-based health center at Aikens High School and a community care center at Hornsby Bend and Chalmers. So those are new initiatives, and the budget numbers are based on the pro formas that we developed for those areas. We've trued up our organization charts based upon how many FTEs are needed at each site to deliver care effectively. And then we have established rates that we use to determine encounters by provider to get us to the total encounters that we expect to see in the fiscal year. We are projecting an overall increase in the FQHC patient encounters. For next year, we budgeted 384,673 encounters for existing sites and about 4,500 for the additional new sites, which brings us to a total of 389,000. Now, this number is decreased slightly for Epic enrollments, our Epic rollout. So we are making plans to move to a new electronic health record, and we are anticipating that's going to impact some of our availability to see patients for about a month. About 11,000 encounters is what we're thinking we're not going to see in this year's budget. But we do believe that at the end of that new EHR is going to bring a lot of new efficiencies and a lot of new data reporting, as well as really enhanced employee and patient engagement. So we're very excited about it. And we are projecting increases in the federal healthcare reimbursement rates, about 1.1% for Medicaid and CHIP and about 1.9% for Medicare. And here you can see kind of the growth of the encounters from the 2018-19 projected, 2018-19 budget, and then the 2020 budget. We aren't really expecting an expansion in dental and behavioral health, and we've got some expansion in medical, taking into account the new EHR. Other revenue, Central Health, the primary care agreement, which was previously with CCC, has been projected with an approximate $1 million increase, and we're still in contract negotiations. And then DSRIP, the budget draft, was estimated using kind of where we've been for the past couple of years, assuming that those measures are going to stay kind of similar in nature, and we'll be able to do what we've done in the past. Increases in operating expenses,
We did increase salaries for merit and competitive market adjustments. We do not have new positions included in the budget other than those that were needed for the new initiatives. Benefits were increased to reflect the fact that employee health insurance is expected to go up. And supplies were increased because we are seeing growth in our pharmacy, which is also offset by growth in revenue. And occupancy was increased because we are expecting to have additional rent on Manor, Oak Hill, and Pflugerville sites, which were previously provided by Travis County. So on the next slide, it will kind of show you the fiscal year 19-20 budget, which actually says 1910 on here, so sorry about that, is the very last column. And we're budgeting about $77,000 in total patient service revenue.
77 million.
77 million, thank you. 47 million of that is from other payers, and about 29 million of that is from Central Health. We have grant revenue at 12.5 million. And then other revenue, Central Health, 15.8 million, and District 10.2, for a total other revenue of 26 million. So total revenue, 115,981,000. So the total Central Health investment that has been budgeted for next year is 45,280,000. When we look at expense breakdown, you can see salaries and wages about 60 million, contract labor about 5.6 million. These are all in line with prior year projections for the most part, and so we come in at about 115 million nine. So we basically budget a zero, a break-even budget is what we plan on. And then for when you look at a cost per encounter, it's coming in at about 297 for next year. We're projecting about 287. I would say if you added on the additional encounters that we are not planning on achieving, you bring it out to about $888 an encounter. So where we're seeing the rise in encounter is not because expenses have gone up. It's because we're projecting fewer encounters to handle the Epic rollout. And I think of particular note, $22 of the current year cost per encounter is the result of David Powell Arch and Care Coordination programs. Compared to our other health centers, the cost per encounter for these sites is much higher than the special population served. And then $34 of the cost per encounter is a result of the provision of pharmacy services to sliding fee scale patients, noting that 22 of the 34 is the actual cost of buying the medications. So that's also why cost per encounter is kind of where we're seeing it.
So back to me. So we think it's important to take a look at trend analysis. Our partnership with being part of the Central Health enterprise is critically important to the services we provide. So I think most of you know that we've been at this now for 10 years. This is our 10-year anniversary with Community Care providing direct services on behalf of Central Health. And they were transitioned, as you very well know, from the city of Austin. So what you're looking at here is a run rate all the way back to when we first started. And at that point in time, around 65% or so of the overall budgetary means were being provided through Central Health in order to support our services. So that goes back to fiscal year 2008, 2009. And so if you take a look and you go all the way, you can see the growth in what our financial means were. We had a budget back then of 31 million and change. We're projecting now on the far right almost 100, and this number's off a little bit because there was a change in some of the previous slides. So it's 115, roughly 116,000 total is what we're projecting, of which around 39% or so of our overall budget means are coming through Central Health. So there's been a dramatic shift in terms of reliance on local taxpayer support to support the operations. And that comes across when we take a look at other revenues that are presented earlier, where we're at $47 million in other service revenue, patient service-related revenue, and we're sitting at about $27 million. And then there's the central health investment of about another $15 million in there to take it to the $45.2 million overall. But you get the proportionality relative to DSRIP, of course, and part of this investment in these funds have come through CCC, now switching back to Central Health for the direct services. But where you see the DSRIP funding back in FY 13-14, that's actually where the contract would have started coming through the Community Care Collaborative for us. And you can see that DSRIP played and is still playing a significant role in our budget. It hit the high of almost 15.5% back in 2015-16. This upcoming year, we're projecting 8.85% of our budget coming from DSRIP. So that's $10 million, extremely important for our services as it looks. But when we take a look at this, those two together with DSRIP and Central Health direct investment through a primary care agreement and some of the other arrangements that we have with you as the applicant, us as the co-applicant, gets us to a little bit less than 50% as a whole. So you're able to see that trend. The next is similar trend rate going back, again, back 10 years. And what you can see here is the growth in encounters projected. And in green, so the encounters you've seen, so back almost 10 years ago, we're a little bit over 203,000 encounters provided. This year we're projecting almost 390,000. Were it not for our implementation, which we, again, as Joey indicated, very appreciative of the support that Central Health is providing relative to the implementation, but also were it not for us implementing, we would have been over 400,000 encounters this year. So that's where it's going to be next year plus, right? So there'd be even more of an increase there in encounters. But then you can also see in green the growth of patients. So 10 years ago, we were a little bit over 55,500 patients. And this year, we're projecting to be close to 105,000 in the upcoming budget period. So a growth of 50,000, almost 50,000 patients in the intervening 10 years. And that's only possible because of the commitment of Central Health to increasing access to care within our community, and at the same time, the commitment of taxpayers here willing to invest to ensure that folks have access to the care they need and deserve. What you're seeing highlighted in yellow, and it starts in FY 2012 through 13, is just the percentage of uninsured individuals. And so you can back up to FY 2018, 2009. We'll true that up for you guys into the future, but it would mirror really what you're seeing in FY 2012 and 13. About 65% of our patients back then were uninsured. And then you can see progressively it started to dip, and then the last couple of years it's gone back up as things are changing. I do want to point out that those numbers are pulled from calendar year. So we're projecting, you're not seeing this on here right now, our budget assumes that we're going to be at 57% uninsured. We're ending, we believe, this calendar year at almost 60% uninsured. So we're going to be partnering with our patients and investing some additional resources to make sure folks who are Medicaid eligible or CHIP eligible, that we're supporting them to a greater extent ever than before under Joy's leadership to make sure that they're getting their renewals done, making sure we're maximizing with our partners here at Central Health to make sure that eligibility for these programs that they're eligible for is realized. So there's a lot of variables in our budget that we expect to hit, but it doesn't always come out perfect. That's why it's an exercise in prediction, right? That's what a budget is. Fortunately, we've been able to go ahead and come close to even every year and maybe a little bit of gain. You saw we're anticipating right now about a $250,000 finishing the year to the good. So happy to answer any questions, Manager Greenberg and others that you may have.
Certainly. Well, first, I want to thank you and your staff for this outstanding presentation and for all the data. I think Cynthia and I have seen a significant improvement, right, of data over the past few years, something that we very much had wanted. So
1,000%.
yes, so we thank you for that. And now questions. I saw that Manager Musaitis has a question.
Well, thank you, Jason, and your team, and welcome on board. And thank you, Yvonne Spelt, for your leadership, and congratulations on your recognition. And this is big, and I hope that you can convey our gratitude and thanks to your staff, and that it means a lot for our community.
Will do. Thank you for that.
I have had the privilege of touring a couple of your facilities, and I plan on continuing further. And it has been enlightening. But one thing in common that I found from your staff is that they all are very passionate in the work they do for the people they serve. And that tells a lot about the compassion they hold for the community. And I commend you on that as well for selecting the right compassionate people for doing this work. I know they have other options, but it means a lot to have providers who care about the people they serve, especially the marginalized, low-income individuals whose needs are greater than the clinical walls. With that said, I understand you're implementing more preventative services in the future with your new EHR. Correct. So, and as on your page number, I believe 7 on this packet, a three-year trend analysis of disease burden. I tend to look at more of the spikes and under chronic bronchitis and emphysema. So I know. So are you? Maybe perhaps you may not have this answer. So is there any preventative preventions around this area, especially in terms of smoking cessation or air quality? So are you working on, are you identifying those individuals and looking further and preventing this burden, this chronic disease that could be easily preventable?
So yes, we certainly engage our patients and their families in smoking cessation, trying to understand the physical environment folks are residing in. So we understand if there's triggers relative to asthma or chronic bronchitis and emphysema. There isn't a preventive measure. We of course do pulmonary functioning testing with our patients as well. That's one where we've actually we were pleasantly surprised that we're seeing fewer individuals reporting having that over the last 3 years. And so when we take a look at that, part of it is making sure folks are linked to these cessation programs. That one of the things that's emerging, which I know you're very aware of, is as it relates to vaping, what impacts that's having as it relates to respiratory illness and problems within our patients. So we are spending some time, and I'll make sure that into the future that we'll have Dr. Shalsha address that specifically in terms of initiatives that we've got going on that one. On the, if I might, on the diabetes mellitus or diabetes, where we're seeing an increase, one of the things that we're trying to do, and we have some support from Episcopal Health Foundation, is we actually want to go ahead and with their support, we have an innovation that's going to look at pre-diabetes and looking at social determinants of health and food insecurity. And so we're going to be, over the next year, with their support, testing someone who is pre-diabetic if they have access to a regular source of food, which will be provided through an arrangement with the Capital Texas Food Bank, or Central Texas Food Bank, I should say. Does it impact the progression of pre-diabetes? So our teams are working on that right now. And so these are some of the population health initiatives that we're engaging in. That we're going to report back to you on into the future, but we're really taking a broader and a longitudinal view relative to how we want to engage with our patients.
Okay, another thing that popped up during my tours, I know that we have this funding services is transportation for our patients, but what I've seen, it's not very advertised. So it is, I didn't see any flyers or anything for the patients to know they have that access. The only way, from what I've learned, is that they go up, it's available, they can go up to the front desk and ask for this service and it's provided. My question to you is for some folks who don't know of the service available, and why can't we just put a note somewhere, a simple paper or page to advertise or to let them be aware of the service available for them. As we know, transportation could be a barrier for individuals to receive care.
Oh, it's a great idea. So we'll take that suggestion back and talk about how we might be able to do that, just so that all board members understand, though, when folks call for an appointment, one of the things that we do assess is whether or not they have transportation needs through our patient navigation center. And so that's when it's offered as well. And certainly with the pilot that we have with Central Health, Southeast Health and Wellness, and CCC as well. And so, but I think that's a great suggestion to have signage that goes ahead and says, if you need help with transportation for your clinic visits, please let us know. Something to that effect, yeah.
Yeah, and I can imagine, because I've seen all your signages also include other languages as well, so that would also be the mirror the others.
Yeah, absolutely, it's a great suggestion, thank you.
Well,
We're not
again,
doing that yet, right, Yvonne?
We're gonna start really
So
I'll be
I
done
think
by
Mr. Giesland and Mr. Burton may have things to add to
Yeah,
that.
along those, actually, I was gonna turn to Ted, I think just in terms of additional outreach efforts, I mean, we've been doing a lot of outreach and pushing this information out through different channels, but in terms of in-clinic, I mean, is there anything that you can inform on that?
I would agree that we could provide signage in the clinics. I think there is some signage at Southeast Health and Wellness Center. Is that correct?
For that
For that pilot.
Correct.
Yeah.
But we could do
But
it
not
more
centralized.
talk
If
to
we
their
have
team
the
more
funds
system-wide.
available.
And it's also messaging that our community health workers are also delivering in the communities as well. So
And the other thing to add to that is we are performing health risk assessments on our patients. We're about 50,000 now almost that have been performed, and one of the things that's assessed is transportation needs. So,
well, I
if-
understand
yeah.
you're doing, and again, I commend all the efforts. It's not any questioning what
No.
you're doing. It's, part of me visiting is seeing, looking at it from a different lens. Let's put that.
absolutely.
It's a simple fix.
Yeah,
It's
thank you.
available. And one last thing, I know that our uninsured rates are unfortunately rising. And to the portion that here on page 20, that you have 59.98% are patients, uninsured patients, are those Travis County patients that you're seeing, or are they part of the 38.888% of Central Health? Are they the same, or no?
So what you're seeing in that lower line on the orange on this particular slide is actually the percentage of funding that we're receiving from Central Health directly to support our services. That's what that lower line is.
That's Travis County.
Travis-
That's MAP and it's Travis County.
That's MAP and sliding fee
which
scale.
has
Well,
to-
in terms of the monies that we're receiving and projected to receive
But they're
next
only
year.
in Travis County.
To your question up at the top line, that's going to be all of our patients, but the vast majority of our patients are Travis County residents. So out of 100,000 unique individuals, about 8,000 or so are non-Travis County residents. What is most interesting about that, and we need to reanalyze this, it's been probably at least 4 or 5 months, and so I apologize we didn't do it for tonight's meeting. But when we take a look at folks who are coming from outside Travis County, Bastrop, Williamson, Hayes, Caldwell, they tend to actually, the patients that are coming to us tend to come in with insurance.
That's right.
About 55 to 60% of those patients are coming in with Medicaid or CHIP. And partly it's because in those communities, especially when we get to Caldwell, some parts of Hayes and Bastrop, especially when we start getting to Cedar Creek where there's no providers around, they don't even have access to someone who accepts Medicaid. So they're coming into Austin and Travis County. And so roughly, and again, this is a little bit an outdated number, we presented it to one of the foundations as we were trying to work with them to see if we can secure some funding for non-Travis County residents. About 3,400 of our non-Travis County residents were uninsured. So just so that so the vast majority are Travis County residents.
No, absolutely. No, I'm not questioning, who are they, as we are looking forward, and I think this is a discussion we had yesterday at Commissioner's Court, and thinking about our patient population and how transient they are and the high cost of living in Austin. I think as healthcare a human right, we need to also think about Central Texas as well. How can we partner with our regional partners to really continue in these services and for not to turn away any patient who needs care at the same time that is paid by their municipality. So I just wanted to just get that point. I believe others will support that or not, but that's my hope in the future how we move forward. Thank you.
So on that note, just to make sure that we're clear, the patients who we're seeing who are getting the MAP program, which is our property tax dollars here from Travis County, they have to be Travis County residents, correct?
Correct. And
Okay.
same thing with
I
our
want to make sure
MAP
there's no confusion on that.
and MAP Basic
And
and
MAP
sliding
Basic.
fee scale, they
And,
have
yes,
to have Travis
they
County.
have to have Travis
So
County
direct
residency.
taxpayer funds for Travis County are flowing only to
Travis
patients.
County resident
correct.
patients, correct?
That is correct.
On the other issue, I frequently dream of a system where, and I know others who have been involved in this for years do, and other healthcare or hospital districts in the state of Texas, where they would be regional and be able to collect regional funding. But that is a matter for the Texas legislature, and it is not one that the Texas legislature has chosen to act upon. Manager Valdez, I think you had some
Yes, I do.
questions?
And I'm gonna start on page 15, because that kind of struck me, that the increase in operating expenses is increasing because previous sites were provided in kind by Travis County. What, are they not providing the money anymore?
So
You
they
have
were,
Maynard, Oak Hill, and Pflugerville sites.
yeah, all Travis County, so the facilities in the transition 10 years ago, those sites have been provided up until this forthcoming year, as of October 1st, they've been provided rent-free.
So as of October 1st, they're not providing rent free.
Correct. And so in our budget, we've got a market lease that's been negotiated between us, Central Health really, through Stephen Lamp, negotiated fair market value relative to that space, and we're paying for that space
In those locations.
at those locations, yes, ma'am.
Are any new sites gonna be in any non-Travis County payable sites?
So the new sites are going to be.
Eastern Crescent.
Eastern
Yeah,
Crescent.
they're gonna be Central Health.
Right.
The modular in Hornsby Bend is gonna be a Central Health facility. The ground lease, as I understand it, with the ESD4 is in place. So those are, I don't know those specific details, that I would defer to Mike as Mr. Giesland is our CEO, and those details. We're not anticipating lease in our budget relative to that. As it relates to Chalmers, which is going to be the housing authority here in the city of Austin,
Right.
that's going to be an in-kind relationship with them in
With
terms of
HACA.
how, yeah, with HACA, correct. And then same thing with the AISD relative to Aikens. There's some build-out space that we're working with your staff here at Central Health, and and you guys are being great in terms of supporting what that build-out is on the facility side. But the AISD and HACA are going to provide that space to us in kind.
Well, what I was trying to do was draw some kind of a justification for why only $1 million increase in your budget when we have all these, we've had a $60,000 or 60,000 person visit, increase in visits in 2 years. We had a 60,000 increase in visits from 17 to 19. And you just told us the numbers about the population that's being served. A heck of a lot more people. And they're sicker. And we have a higher increase of uninsured, and yet we're only talking about $1 million increase to community care in our budget. I just would like the managers to know that if we have an opportunity to increase their budget, I think it needs to be more than just $1 million. And I think that if we need to put together a fact sheet to show that, these are the people that we're supposed to be serving, okay? These are the people that we're supposed to be serving, not, I mean, we can serve other people in the community and we can do all these other initiatives, but these are a poor population, and those are under 200%. And I think that we need to reflect that commitment in terms of dollars, especially in light of the fact that you might not be seeing monies coming from Congress. You're not going to be seeing additional monies coming from Travis County, as you were previously saying. So there's a lot of numbers I can throw out here and see that, prove that the need is there for increase in millions of dollars as opposed to one. And then with respect to the outreach and eligibility. Eligibility is now Central Health responsibility. It's not Community Care's responsibility. Is that the way it is?
Yes, the
I just wanted to
enrollment
fill out Matt
eligibility
from
team
that, and that
is
basic.
still part of Central Health. Now, there are eligibility that are staffed within community care clinics.
Okay, so how is your staff doing with respect to following the patients, since they're only MAP eligible for 6 months? Maybe making sure they don't get dropped off and bringing them back, because, what was that, 11,000 that you're gonna have to hold off on because of some,
The electronic health
technology
records
related-
going into
electronic
effect.
health records.
11,000 visits, correct, yes. But that's still above what we were going to perform this year. But yes, that's correct. And we do, with our partners at Central Health, we coordinate very carefully and well with Central Health relative to MAP eligibility. But we screen probably through just community care directly for MAP Basic, sliding fee scale, probably close to 65,000 folks a year coming through our doors
How
that
many-
we're screening for eligibility.
How much staff do you have in your whole community care?
On the eligibility front
No,
or
just,
total?
Total and then eligibility.
Sure, total, it's a little less than 900 right now. We didn't provide the FTE, we'll follow up with the actual FTE count.
Okay.
So 900 roughly in terms of full-time equivalents,
Got it.
because we have part-time individuals,
Right.
going to be more than that. We'll get you those specific numbers. On the eligibility front, last number I had was 17. Is that what you, yeah, so 17 eligibility workers that are involved with that.
We're screening 65,000 people. That's.
Yes.
Yes,
they'll
that's
do a good
correct.
job.
Yes, they do. It's
But
team.
we have a lot more people that are not being enrolled in the program that are eligible. And so those are the people we're trying to hit with our outreach and community, and increased community engagement focus in our poverty communities. I just, there's a lot I need to read into this, and just seeing it, not saying that I would have liked more time to have this.
That's our
But we'll
fault.
have other
Oh,
opportunities
yes.
to discuss this. And so I just want to thank you for the job that y'all are doing. I'm a big believer in community care, and I would like Central Health to be reflective of our support of you in terms of dollars. So just where we can be perfectly clear where I stand. Okay, thank you.
And if I may, Manager Greenberg,
Yes.
so my apologies, no one else. We should have had this as part of your packet when it was mailed out last Friday. Miscommunication on my part. So I
That's okay.
apologize it wasn't included. So that's why you're seeing it for the first time
We
earlier
know.
today.
We know you stay very busy, and we certainly appreciate all of your hard work. And this is our population, absolutely, and we want to do everything we can to serve our population. I can't help but note that when we see that Travis County is no longer providing
Assistance.
those facilities in kind, that this happens to coincide with the property tax revenue cap that was passed in the Texas legislature that will go into effect next year. So I can't help but think that that's probably not a coincidence, and that is just part of this overall mix that you were describing of all of these moving pieces in finance that we're seeing.
And as far as I'm concerned, the provision of some direct services is a priority for me. And so entities that provide direct services, are going to be rated higher in my world of people who are living below the poverty line, and people who are uninsured and needing services, and the huge immigrant population, which I know is not coming because they're afraid that they're going to be kicked out of the country. So anyway, or have family members deported. I want to just thank you for all the work that you do, all of y'all. Everybody.
Yes, absolutely. Other questions, managers? Yes, Manager Jones.
I'll be as concise as possible. I don't have a lot of questions, just quick yes and no if you can answer if possible.
Yeah, absolutely.
So on the calendar of 2018 patient characteristics, are these are all Travis County residents?
Entire population,
Okay,
everyone
so-
served. We do have it, but, so the way it's reported, Shannon, is based on zip codes. So zip codes, of course, don't follow county lines, so it's difficult
Right.
for us to pull it that way. But we can give you a good ballpark on that, so we'll follow up with that.
And congratulations on your award. You're to be commended
Thank
for
you.
the entire staff. We acknowledge that. Second one was, can you provide on page 7 where you have the 3-year trend analysis of disease burden? Do you have that by race and ethnicity? Is that available to be ascertained from your?
It is, and we can provide that. It'll take a little bit of time, so we'll follow up with that one as well.
If you could, I
Yes.
would appreciate that.
If I may,
To the board, yeah.
just to add that, can you also include zip codes or no?
I don't know. I'll verify with our analytics team if we can do that. What we can certainly do is, and we're not there yet, but what we are planning on doing with some of our chronic diseases is doing hotspotting, where we'll actually take someone with a
Yes.
diagnosis, put it on a map, and actually
Yeah.
be able to see, do we have a concentration somewhere within the community? But yes,
Heat mapping.
yeah, you got it, yeah.
Okay,
Thank you.
next question is, on page 10, I'm just interested, the impact of the healthcare fund that you were talking about, the impact. Where are the congressional representatives in the states, in Texas stand on that issue?
So here in Central Texas, they're very supportive.
All of them or just
The Democrats.
Travis County?
So certainly Congressman Doggett, that had an opportunity to meet with him in his office in Washington 2 weeks ago, very supportive. It's part of where we had a conversation about the surprise medical billing impact, and that was not with him directly, it was with his staff, but I met with him at the beginning. And then we've met with Congressman Chip Roy and others, and so they're balancing it based on what they see as priorities and that. So they're supportive of the health center program as a whole. I think what I would communicate is that they're trying to balance all the other financial pressures from at least that, the Republican delegation within our area.
Well, you're very tactful and I appreciate it.
Let's let him know.
I think the citizens of Travis County should be aware there are representatives that may not be supporting some of this effort. The balance is maybe, but this is a very important fund that supports many people in Travis County.
That is
They should
correct.
be aware that their representative may or may not be supportive of that. So I just want to.
Your report card.
We
Yeah,
can
exactly.
provide how folks voted last time, and I think Perla could pull that, Mike, if you don't mind getting us some help on that, and then we'll see where it falls. We've had productive conversations with all of our congressional delegation. Congressman Williams has been supportive, Congressman Roy, McCall, Flores.
Well, I don't need to allow
McCall,
my time
not
is
so
short, so I
much.
just want.
There are various associations that provide this and various report cards that I'm sure that Ms. Cavazos can
Okay,
pull for us.
if I may go on, because I'm trying to expedite this.
Yeah.
On page 12, you're talking about the budget. So with regards to Chalmers, what impact, and I don't know if I've asked this before, will that have on, will Sandra Joy have as relates to that, with what you're doing? And I think I talked with Mike the other day or someone with regards to East, Chalmers, and Sandra Joy. So we have 3 locations there. Are you looking at the distribution of services in that area in light of all of the changes that are occurring there?
So great question, Manager Jones. So we don't anticipate an impact on Sandra Joy Anderson. That's a fairly new health center, as you know, built in 2015 or established in 2015. Chalmers is really intended 2 things. One is it's going to be a very small medical footprint, 1 provider on site. There's 2 smaller buildings, 2,000 square feet in one, 3,000 in another. Smaller one will be built out as medical, so 1 provider, eligibility staff, others. Population at Chalmers Court, as you very well may know, is going to increase because of the redevelopment of that
Right.
particular housing development. And so they're anticipating 3 times as many individuals and families coming in, and so the population is going to increase. The 3,000 square foot facility will allow us to bring dental services for the first time into East Austin. And so that's important for us. I think as it relates to our East Austin Health Center, which was our original on 4th and Kamal, as you very well know, that is a pediatric OBGYN. We've talked with our staff in that. For the foreseeable future, that will persist. But the reality is that pediatric populations and OBGYN populations being served from that site are coming in, for the most part, from miles away. So as we continue our work with our partners here at Central Health and health center realignment and where our assets need to be, as Mr. Giesland has so eloquently stated before, getting more proximal to folks, we're a strong believer in that. We want to take our health centers closer to where folks live, be that in Del Valley, Colony Park, Austin's Colony, Hornsby Bend, Dove Springs, Runberg, those are the high need out, Pflugerville,
Yeah,
those are the high need areas moving forward.
Well, I appreciate that. I'm
Yep.
trying to expedite
Yep.
this thing, got a couple of more. One is, what is the impact of the electronic medical records? Why is that gonna have a decrease in the utilization for that? Is it could you just?
Yeah,
quickly tell me what this
twofold.
is?
So it's a dramatic change for our staff. And part of it's so prior to going live, which means when we flip the switch on the new electronic health record system, we have to have our staff the ability to be trained on the system. So we have to reduce schedules as a result for our clinicians and care teams. And then post go live, after we implement the system, what we have to do is it's very typical to reduce the schedule while providers and care teams are learning to navigate the system in real time with patients. And so roughly 11,000 visits equates to 0.4 months of service, so a 0.4 months of service. So that's why there's a decrease of 11,000 visits. Again, as Ms. Sloan was indicating earlier, we're going to see an increase in not only efficiency within the system, we think it's going to increase our ability to serve the community more comprehensively, but also enhance our ability for our providers to go ahead and see patients. The system that we have currently in place is antiquated and is not performing the way we would expect it to be performing. So this modernization will really help us on a go-forward basis once we get through the
And
implementation.
just two more quick questions.
Yep.
One is, the location at Maynard, my question sort of piggybacks off of what Manager Valadez said. Maynard, Oak Hill, and Pflugerville. So those sites you're going to have to start paying to utilize those.
Yes.
Have you considered other locations, as you look at the Eastern Crescent, that might be able to be economies of scales in terms of proximity to locations in lieu of having to utilize those facilities?
Yes, those are considerations we have. And currently, we're evaluating Maynard right now. Oak Hill works very well for us, as does Pflugerville. Pflugerville is a broader conversation. We have 2 sites in Maynard, and we're evaluating what's the best path moving forward. When we're paying competitive market rates, it's only prudent financially and from a service delivery for us to take a look at it.
My last question relates to Medicaid. What kind of marketing do we do with Medicaid residents in Travis County for the utilization of our services? We say we get a sizable number outside of the county that come in for services. Do we actively advertise for them for utilization?
We do. It's based on the services. So really, the vast majority of our Medicaid patients are Travis County residents. That was just in reference to the non-Travis County overall. So when we look at our Medicaid population, almost 27,000, 28,000 Medicaid CHIP, the vast majority are Travis County residents. But they're coming to us 2 ways for the most part. They're coming to us as pediatric patients, and they're coming to us as prenatal patients. And then the other smaller subset is about 2,000 folks who are dual eligibles, of which are Medicaid and Medicare covered, that will serve as well. And that's just an artifact of what the program is. Do we actively market? No, because we have limited capacity on both the prenatal and on the pediatric side. We monitor what our availability is on both. And as you very well know, one of the initiatives we have coming on, we didn't put it in this because it hasn't been yet approved by the federal government relative to Health Resources and Services Administration, is our absorption, hopefully later this year, as it relates to carousel pediatrics.
Okay. All right, thank you very much. I appreciate
Yeah,
it.
of course.
And any members who haven't had a chance to ask questions yet who wish to do so? Okay.
Mine was just gonna be one.
Yes, sure.
On the request for information, the over 65 population.
We can do that, absolutely. And I can tell you that it has grown over the last several
What's
years.
their demographic?
We can do that as well. And we do think that that's an opportunity more for us moving forward to help, especially lower income,
Eligible.
older individuals. Yes, ma'am.
Okay,
Yeah.
thank you.
Quick question on those, again, those Travis County sites. If I'm not mistaken, I know at least Oak Hill was one of the rural health clinics that the county used to have, that the city ran and then came over to us. And I don't know if the others were relics of that either.
I don't know,
Yeah.
Yvonne, do you know? Is it all right if she answers
Is
for?
that
Yes, so the Oak Hill.
was one of the rural
was
clinics?
one of the rural
so was Maynard and.
That's what I thought.
Yeah.
Those were all,
Yeah, all three.
yes, and that just ties in with what we're talking about with the changing demographics and gentrification and some of the
Displacement.
involuntary displacement. Because if we go back 20 years, you know, Maynard, Oak Hill, and Pflugerville were rural health clinics that Travis County had, that they entered into an interlocal agreement with the city of Austin to run for them. And now we see that these are urbanized or urbanizing or suburban areas. So I couldn't help but notice the changes that we have had, and I certainly applaud you. Our effort is to go to where the people are, and we do know that that is continuing to change. Also, it's heartbreaking that once again Texas has the highest uninsured, and we know the effect that not expanding Medicaid has had on some of these costs and the folks that we continue to serve. But congratulations on all that you do. Congratulations on the award, and we really appreciate everything you're doing. Thank you.
Well, we do it in partnership with you. It's us, right? It's our efforts, and so thank you as always for your
I
support of the
also-
communities we serve.
I also want to note that if we look back on this trend analysis you had on page 20, the number of unduplicated patients has pretty much doubled.
That's right.
Doubled. And that's a trend that we're only going to see continuing. So thank you again.
That's why the budget numbers are important.
All right, members. There's no action necessary on this item, so thank you very much. We'll move on to agenda item number 3, discuss and take appropriate action to A, authorize the execution of all documents necessary for Central Health to obtain a capital line of credit from J.P. Morgan Chase, and adopt a board resolution authorizing these finance expenditures and reimbursement of Central Health funds from finance proceeds. However, I think there have been some changes in this. I will turn it over to Lisa Owens and Jeff Knodel, who will present on this item. Thank you.
Yeah,
Thank you again.
Thank you. Just as a quick reminder, this is an item related to a line of credit from J.P. Morgan in an amount. We're requesting a line of credit authorization in an amount of $10 million, basically for furniture, fixture, and equipment. And equipment would also include information technology or IT type projects, which is really what we're targeting. Project-wise, the main project that we were looking at funding was the EHR. Actually, there was some conversation related around that, what was called the EPIC system. Unfortunately, related to the item, we're just giving you an update on previously existing information and a slight update. So we don't have all of the required documents to bring forward to you as the board for approval. We will continue to work on that. We are, however, in trying to keep through as much of a expeditious process as we can. We do plan to take this item to the Commissioners Court next week and request approval for the line of credit, in addition to what's called a reimbursement resolution, which is simply a document that just says if you pre-spend project dollars before you actually draw or receive funds, you have the authority to reimburse yourself. So the kind of the updated plan would be to go to the Commissioners Court next week. We are pledging our debt service property tax rate, so we will request approval for the line of credit. We will come back to either our budget finance meeting or the board meeting in late October, bring back the necessary documents and request approval to authorize a line of credit for $10 million related to those project purchases that I outlined. So we're not requesting any action, simple update, slight change in the timing of plans, and I'll be happy to answer any questions.
Thank you for the update. This seems very reasonable to me. I know these documents can sometimes take a little longer than you would like, but it seems very reasonable. Since it is debt, we do have to have the county's approval. And we do want to expedite this, particularly given what we heard of the EHR, but you will come back to us, of course, for the actual document. So it seems very reasonable to me. Members, any questions? All right.
Thank you very much.
Thank you for the update. Appreciate it. That brings us to agenda item number 4, discuss and take appropriate action on an interlocal agreement between Central Health, the University of Texas at Austin, and Emergency Services District 11 for the establishment of a healthcare clinic in southeast Travis County. Mr. Gizon will be presenting.
Yes, so I'll open it up and then I will actually, if I may, hand it over to council.
Yes.
Walk through a couple of terms. But,
Yes, absolutely.
As you know, the board has previously approved some terms for an interlocal agreement. And we felt it was important to come back to you because I think there are some things that I can execute on under the previous authority that you've already granted me, but there's some things that, in talking with Holly, we needed to bring back to your attention this evening to ask you to ratify. Probably and this is my opinion, but one of the more significant ones is the actual opening of the clinic itself. And there's a date in there, I believe, of September 30 of 2020. And members, on the screen is the terms that council will speak from that you've seen before in prior board meeting, but an open date in September of 2020, and you'll recall in December we had estimated an open date sometime in 2020. And so that's still, within respect to this document, the desired target. But there are a lot of things that are going to be outside anybody's control. Once ESD 11 starts construction, it could be materials delays, permitting delays. Weather's already accounted for in force majeure, but there's a lot of things outside of force majeure that if you're in the construction business, that you just simply can't control. And so I think we're willing to recognize that. And if notice is provided, we can, one, it helps us to know, but two, we can also go back out to the community and say, here's what's going on in terms of moving to opening date back to following month or 2 or 3, whatever the delay is. So with that, I'll turn it over to council.
Right, so as Mike mentioned, on the right side of your slide here, in the very last text there, I talked to you about the recoupment events. Those are events that would happen where ESD 11 would repay Central Health for its investment if something went wrong. The 2 terms that ESD 11 asked
Mike.
us to, thank you. Let me move this a little closer. Asked for us to change were around the date that clinic design needed to be completed by. And so the date in the original agreement that we discussed on August 28th was January 1st, 2020. So it was a very short turnaround time, and ESD 11 asked that we allow them 180 days after the date of agreement execution. So essentially adding, perhaps, if we execute this agreement tomorrow, 3 more months to the timeline for design. The other date that ESD 11 asked for us to consider changing was on the opening date for the clinic. So you'll remember that we presented a September 30th, 2020 date. The request back, we were never very firm on a deadline. I think, as Mike pointed out, there was concern about what happens if there's a force majeure event, or what happens if there's a construction delay because of materials, things like that. So Mike proposed what I consider to be a middle ground, which is we keep the date of September 30th, 2020, but ESD 11 has the ability to provide us with notice prior to that date that they will not be able to meet the timeline, and provide us with a timeline that they do believe they could meet. And so the reason this is coming back to you is because ILAs, or interlocal agreements, have to be approved by the board. And the board approved on prior terms, and so now that the terms have changed, we wanted to keep you informed and ask you to ratify those 2 changes. And that's pretty much all I had to say to you.
Okay, I believe we need a motion on this, is that correct,
That's
council?
correct.
Is
So
anyone-
Holly, you're recommending this, move forward on this language?
I know it was really important for the board to have a clinic open as fast as possible.
Right.
I do think this is a good middle ground. It's not our most favorable position, which is what we put forward, but it certainly is a reasonable one, and I wouldn't counsel you against agreeing to it.
Okay.
You Make a motion?
Yes. I move that the board ratify the modified terms negotiated by Central Health staff and the interlocal cooperation agreement between Central Health, the University of Texas at Austin, and Travis County Emergency Services District 11, which was previously approved by the board at its August 28, 2019 meeting, and provides $1.15 million in funding to ESD 11. I didn't know we had previously approved it. Did we previously approve this?
We did on August 28th. We took a vote.
Okay, sorry. Okay, in funding to ESD 11 in the fiscal year 2020 budget to establish a healthcare clinic in the eastern Travis County,
We have a motion by Manager Valadez. Is there a second? Second by Manager Bell. Discussion on this item? Yes, Manager Musaita?
I certainly believe this community deserves services, and they should have been yesterday, not in the future date. And given how this agreement is not clear on a date, and my fear that this will delay further, that we won't have a September 30th, 2020 opening date, and that it will probably take more time, and I don't know how, many more months for this clinic to be open. And this is something that we've committed to the community a long time ago, and the delays of this agreement due to several issues. And I personally I can't support this, so for this delay, so I won't support it.
Any other questions or comments, Manager Jones?
I'm just wondering what's driving this change. Is it because this is a contract between us and the University of Texas at Austin and the Travis County Emergency Services. So is the concern in terms of the construction, is that a UT issue or is it a emergency services district issue?
So it's an emergency services district issue because ESD 11 is responsible for repaying any of the funds if the clinic failed to open on September 30th, 2020.
So I guess the question, it goes to sort of what Management Saita said, is that, are we going to ever have this thing open? Because there seems to be a lot of issues with getting this done. And I guess that's the sense of my concern.
Closed session?
Well, I don't think that's a legal question.
Well,
I can't
that's-
unfortunately answer whether ESD 11 will be able to get this done by September 30th, 2020.
Is UT School of Nursing out there operating now?
Mr. Giesland, would you like to respond to this?
Yes, they are operating now.
And they'll continue under that operation.
Yes.
Are they comfortable with it? Or would they not like to expand?
I'm sorry, could you ask the question?
Are they comfortable in the current location where they are? Wouldn't they like a larger facility as soon as
Well,
possible?
the problem is that they're not allowed to see adults
Yeah, that's
in
right.
this location. It's
Correct.
pediatrics only, and so they're needing, in addition to changing their patient mix, but also they need a space where they need more space where they can see adults.
So the longer it takes for us to get this done, the more delayed they have in getting adults seen.
Potentially, unless the school board out there is willing to make, because they're on the school campus of
Right.
Del Valley ISD. Unless there's, and again, I'm not involved in the middle of the negotiations between UT School of Nursing and Del Valley ISD, but if there's some type of arrangement that allows them to see temporarily, that would be the only way that they could see adults at that site.
Well, my
Until such
concern is
time
not-
that this opens
My
up.
concern not so much with UT School of Nursing is what's going on with our relationship with getting this done.
Right.
And it sounds like it seems with the other, the ESD, so.
And, well, we had discussed this,
Holly, do we need to?
well, what I'm about to respond to, I feel like it's certainly open session material, but
Okay.
we had discussed this back in June, I believe, and forgive me if I don't remember who all was in attendance at that time, but just in a general sense, this is my estimation of it. You've got three parties of it that they're all governmental entities. We have different governing bodies, different statutes. we've never really worked together on something like this. And this isn't just about building a building, it's actually standing up a clinical operation. And so I think there's a lot of, you know, well, there's some models that they've looked at in terms of advanced practitioner clinics. I think there's a lot of having to figure out and learn as we go along, just to be blunt about it. And, you know, to answer your prior question, you know, is this ever going to get started? My sense is that, you know, we have worked very diligently and we've worked through numerous versions of different business arrangements. With this and with this ratification, I feel like this is something that I can sign. And at the end of the day, if either one of them has, you know, change of heart between now and next week or whenever we can get a document together, then at this point I feel like I'm probably out of ideas. And I just need to move on and continue to look for additional space, which we're currently doing anyway, because community care ultimately needs to expand, you know, their operations where they are in the temporary location, the Travis County Employees Clinic.
Okay, well, I just want to go on record that
I feel like we can get this done, because when I'm sorry to interrupt, Manager Jones, I left out an important point.
well, I was just saying is that at the University of Texas, the School of Nursing, I guess, the provider here, needs to be able to provide services. And if the facility, the landlord or whoever's going to oversee this can't get it done, then we might need to look at working with them through another facility, I guess that's what I'm saying.
Understood. And I've spoken with the chief before, in fact, as recently as today, and then with Dr. Morgan. And my sense is from both of those partners, they're very dedicated to getting this done. Again, they're just trying to, not having done this sort of thing before, making sure that they know what they're getting into.
Anything else? Manager Zuniga?
It feels like they'll do this with us or without
Yeah,
us.
Jill.
Sorry, if you want to discuss, the board has to vote to allow you to discuss.
Oh, okay.
Oh.
You can vote against it.
So,
I'm sorry.
Because I'm with School of Nursing, so you have to
Right.
vote when we
Oh.
talk.
Yeah, because of the conflict
right.
of
Is there,
interest.
okay, this is, I think, something that we have not specifically dealt with or done, to my knowledge, since I've been on this
We have.
board.
We have done it before, and we did it with Julie, we asked her to leave the room.
Okay,
And so I would not want us to take a different
okay,
stance.
that's what I couldn't remember if this has occurred in the past and what we did, that's why I was asking, yeah. What,
You want me to leave the room so you can vote?
No,
Oh.
no, I think it was,
it was for her to participate.
Oh, for her to participate.
okay. Manager Musaita?
Well, I understand and that we have the votes to move it further. My position is really a clear statement that I cannot continue on with these provisions, not knowing an expected definite date, and this community deserves more. And that is really my position and where I stand. It's not in against to, I believe every party is well-intentioned. There's well-intentions from all, us, UT School of Nursing, and ESD 11. So it's not retained to anyone's intentions. My position is clear statement is that we need to have a definite facility that can provide services as soon as possible. Further delays will not do them just. So that's where I stand. Thank you.
Manager Oliver?
If I'm hearing Holly correctly, I think the reason why we can't nail down a specific date is because there might be things out of our control,
That's right.
like weather conditions
Active
or,
guns.
I don't know, tariffs on steel. I mean, you know, things like this that might truly be out of the control of the three parties of us. And did I hear you correctly that that's kind of why we're fuzzy on some of the dates?
Yes, and one of the other things is the city of Austin has to provide permits for this
Yeah.
space.
Right, yeah.
And so the permitting process can sometimes take longer than expected. And so I think they are hesitant to agree to a set date because of some of the unknowns.
Yeah, and I don't, from what I'm hearing from you, I think, maybe you might be saying this, that they're not intentionally dragging their
Right.
feet. It really is things that they're concerned are outside of their control.
No, to be fair, I have an email from Chief Bailey today, and he said, "We want this project done as quickly as possible, and we'll make every effort to achieve the goal of September 2020, but to bet $1,150,000 on that data is not justifiable to our taxpayers."
Manager Jones?
And then my issue is with ESD, not school nursing, because they are the landlord, I presume, for this. Then the question is, are they able to manage this activity? We've been through this for quite some time, and it just keeps coming back and coming back with changes. So my just question is are they able to do this?
Holly, do we need
It's somewhat frustrating.
So I just want to remind everyone that if you do want legal advice, we have the option of going into closed session. It's a little hard for me to follow whether we're wanting legal advice or whether you're wanting to know from Mike a sense of, can we get this done?
Can we get this, can we depend on
Yes, I believe we
ESD to
can
get
get
this
this
done? If we go ahead and give them this flexibility, that could be 2020, it could be 2040, as far as we're concerned.
If we get this signed, then I think we can get this done. If we don't get it signed, then we move on.
And if we don't get it done, it's,
Then we've got
we're not
something else.
quite at square one, but we're kind of back to square one.
Right, and I mean, just full disclosure, we are, actively seeking other property
Right,
opportunities out there.
right. So as I said, we're not quite
Community
to
care
square
is
one,
right.
but we aren't,
Yeah, we're gonna have to.
we aren't further down the road.
You're at square
Yeah.
someplace. You're close to square.
Okay, is there any other, just to try to keep order, are there
No,
any other
because you won't
members
vote
who?
for me to talk. Will you vote for me to talk or no?
Oh, we do need to get
There needs
back
to be a motion.
to that, so there needs to be a motion. Sorry, we got called on other members.
So how this would work is
Yes.
we would make a motion to allow Manager Zuniga to discuss despite the duality of interest. It would need to be seconded, and a majority of the board would need to vote in favor of that discussion.
I move that member
Soon.
Julie be allowed to participate in our discussion.
Manager Jones moves. Is there a second? Manager Bell seconds. I have a question, because I am an employee of the LBJ School of Public Affairs that is at the University of Texas at Austin. So is this something that I should abstain from voting in?
Yes, that would be
That is
our
my
recommendation.
understanding, that I, just so my board understands why I am abstaining, and so Manager Zuniga understands why I am abstaining.
Madam Chair, I'm sorry if I could split this question here, and I know that you're talking about abstention for the vote on ultimate ratification, but what about on the procedural
No, I'm
matter?
asking about both.
Okay,
So for discussion, if you wanted to discuss, you would also need to be part of that motion.
Right, so I need to abstain
From voting, yes.
from voting on both.
On this motion.
And the other. That is my understanding, but I wanted to make it clear to my colleagues on this board why I am abstaining on both of these. Okay.
And then I'd like to, we have a motion and a second on the floor.
Absolutely. A discussion?
And Julie, just so you understand, I was one of those people that felt that people should have an opportunity to speak, but my friend sitting next to me was not given that opportunity, and at this board level, and because there was a claim of conflict, and even though I don't believe that there was a conflict, she, out of the goodness of her heart, accepted that. And I'm just saying that I think that it's only fair that if we're gonna treat one manager in such a fashion, that we should treat all our managers the same way. And that's the only reason I'm bringing that up right now, as much as I would love to hear what you have to say, but
I don't need a reason, let's vote.
Okay.
Vote yes,
so-
vote no, let's
so
move on.
is there any other discussion? If not, all in favor of the motion in front of us, vote aye.
which motion, which is.
The motion in favor of us
Shannon.
is the motion
Tell that to-
that the manager Zuniga would be able to discuss this. If this motion fails, then she will, because of the duality situation, not be able to participate in the discussion. So if you are voting yes on this, or aye, you are voting for Manager Zuniga to participate in this discussion. Is that right, Counselor?
That's right.
Okay, so all in favor, voting aye, voting yes?
Aye.
So we have, I count two. All opposed?
Aye.
I count three. Abstaining? That would be, okay, that motion did not pass, okay? So we are now
On the original motion.
on the motion before us, which is the motion on ratification of the modified terms as brought before us. I believe that was Manager Valadez and then seconded by Manager Bell. Again, I will be abstaining from this, but we are now taking that vote. All in favor, please vote aye. Opposed? Abstaining? 2 abstaining, myself and Manager Zuniga. 1 opposed, Manager Musaitov. The motion does pass. The next item before us, managers, is agenda number 6. Agenda item number 6, discuss and take appropriate action on an update regarding Sendero Health Plans, Inc., including the effect of federal legislative and regulatory actions. And who will be presenting this?
So,
No motion will be necessary on this. Members, there will be no presentation or action on this item since materials were made available to you on Friday and again in the board packet. However, Central Health staff are available to answer any questions you have. There will not be any motion on this. Are there any questions that anyone has at this point, given the information that was, and materials that were made available on Friday and again in the board packet? Hearing none, then we will proceed to agenda item number 7. Agenda item number 7, discuss the 1115 Medicaid waiver, delivery system reform incentive payment, DSRIP close projects, the Community Care Collaborative, including healthcare delivery arrangements, and other interrelated community partnerships. I announce that the board is convening in closed session to discuss agenda item 7 under section 551.085 of the Texas Government Code, governing body of certain providers of healthcare services. Who needs to stay in the room? Mr. Giesland?
of course, council.
Council will stay in the room.
Myself and
Mr. Giesland and
Jeff and Monica.
and Jeff and Monica. Okay. I'm announcing that the board is reconvening in open session. There will be no action taken on item 7. I am going to now move to agenda item number 10, confirm the next regular board meeting date, time, and location. The next Central Health Board of Managers meeting will be held on Wednesday, October 30th, 2019, at 5:30 p.m. at the Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I'm ready to accept a motion for adjournment. Manager Valadez.
Second.
Manager Bell seconds. All in favor? Aye.
Aye.
Opposed, same sign. Abstaining? We are adjourned.
Thank you very
Thank
much.
you, members.
Great
So
job.
when is the next meeting with Commissioners Court?
Next Tuesday. We don't know the time yet. They'll hopefully find out on Monday.
That's close to.
Yeah, they don't let us